Hi, I'm Michael Gropper from the University of California in San Francisco. I wish I could be there in person, but I'm happy to talk to you. I'm going to talk to you today about protecting lungs from harm in the OR and the ICU. My disclosures are here. My spouse is an officer in Kindbody Incorporated, which does women's health. I won't be talking about that. And I do receive royalties from Elsevier for the Miller textbook. So mechanical ventilation has been around for a long time. In fact, one of the earliest descriptions of it you can see here, this is a picture of Vesalius, who was able to provide mechanical ventilation by using a reed that you can see in the bottom right. And by blowing that into the trachea of an animal, he was able to resuscitate that animal, and that the lung would be inflated and the heart would continue to beat. It's probably the first description in 1543. But the modern era of mechanical ventilation is thought to have been when the polio epidemic occurred in 1928. And certainly your institutions at Harvard had an important role in this. This is a picture of the polio epidemic in Copenhagen, which hit Denmark particularly hard. You can see that these are cuirass ventilators, or the Drinker respirator, as it was called, named after Philip Drinker, who was at the School of Public Health in Boston. And these are interesting devices. You can see that there are many patients in this ward. The body is held inside this cylinder where there is negative pressure that's cycled. And with the negative pressure that would cycle inside the cylinder, the chest wall would rise and the patients could be ventilated. This worked particularly well in polio because with the weakening of the muscles, the chest wall compliance was very good. And interestingly enough, as you can see that the head of the patient was outside the cylinder, and so the patient could talk. There could be communication with the nurses. However, there were certainly risks. This was often inefficient, particularly with larger patients. And you can imagine any sort of nursing that needed to be done, the cylinder would have to be open. And at that time, the mechanical ventilation would stop. And so this also led to the first use of tracheostomy and positive pressure ventilation. That ventilation was actually done by medical students. They would be on 8-hour shifts where they would sit at the side of the bed of the patients with polio, and they would squeeze the bag. And this was also really the beginning of the role of anesthesiologists in the care of patients in the intensive care unit, because they were the ones who had the expertise in mechanical ventilation and understood the physiology behind it. So mechanical ventilation has obviously been a major advance in our specialty and in the care of patients, both in the operating room and the intensive care unit. However, the ventilator does have downsides. And there's, of course, the entity of ventilator-associated lung injury, which is something that we've become more cognizant of over the last 30 or so years. I'm going to talk a little bit about that, talking about how we've understood that both in the intensive care unit and in the operating room. So if you think about ventilator-associated lung injury, there are 4 elements to it. Barotrauma, trauma from pressure on the lung; volutrauma, trauma from excessive volume; atelectrauma, from the repeated cycling of atelectasis and then lung opening; and finally biotrauma, which is really the final common pathway as there is repeated atelectasis and opening of the lung, which leads to inflammation, as I'll talk about in a moment. So if you think about the alveolus, it's a beautiful, delicate structure. As you can see in this electron micrograph, you see a red blood cell in the middle. And importantly, there's a very narrow barrier between the red cell and the alveolus, which is on either side here, so that it can be rapid gas exchange, particularly of oxygen, but of course also of carbon dioxide. So in developing this structure, the human body has a great high efficiency machine as blood moves through the lung, but at the same time, it's quite delicate. And you can see that if you were to stretch this or push on this, that it could be easily disrupted, and then you will affect gas exchange. So barotrauma is parenchymal injury of the lung that results from high intrapulmonary air pressures. It's something that we all get concerned about, whether in the ICU or the OR, when we see the peak airway pressures rising to higher pressures above 30, 40 centimeters of water, we get concerned that the lung will be injured. And indeed, it's true that most studies estimate that barotrauma occurs when the plateau pressure exceeds about 35 centimeters of water. And in fact, we can see the results of that if you look at a CT scan of a patient with acute lung injury. You can see, particularly in the bottom right, that there is now pneumothorax that you can see here. And those of us that have been practicing for a long time in the intensive care unit and before the advent of protective lung ventilation would take care of patients who could have 5, 6, 8, 10 chest tubes because of multiple pneumothoraces that could be life-threatening. And I think if you're in modern critical care practice, you just don't see that anymore. And that's a part of what I will talk about today. Volume trauma is direct injury of the lung parenchyma from just stretching. As you saw in the previous CT scan, there are different parts of the lung that have different compliance. And because of that, they will have different susceptibility to overinflation or volume trauma. And what happens is that you have some normal areas of the lung that are obviously more compliant than the atelectatic or diseased areas of the lung, and therefore a disproportionate share of the ventilation or the tidal volume will go to those normal areas of the lung and further injure the lung. So for example, here, if you look at high airway pressures and high tidal volumes, you can see this is a measure on the x-axis is airway pressure, on the y-axis is permeability. This is work from Parker and Guyton. You can see at about 35 centimeters of water that permeability starts to increase. As you can see here, this is just the weight of the lung, in other words, a measure of pulmonary edema. So as the pressure increases above about 35 centimeters of water, this is transpulmonary pressure, you get increased capillary permeability and the lung begins to develop edema. You can see this in an electron micrograph here. You can see an airway here, and you can see around the airway here, you can see red blood cells in the parenchyma. These are alveolar walls here. So this is a beautiful electron micrographic demonstration of lung injury caused by high tidal volume. And you can essentially see bleeding into these perivascular fluid cuffs around the airway. Atellect trauma occurs when there's repeated collapse of the lung and then opening of the lung with every breath. And what happens is that when the lung collapses and gets atelectasis and then is reopened, there are very high shear forces that occur at the air-liquid interface where the pulmonary edema is in the lung. Now, this shear force is normally minimized by the presence of surfactant, but of course, surfactant can be depleted during acute lung injury with oxidant injury, hyperoxia, and other factors. And so you will get very high pressures in the lung that result from repeated opening of the lung. And as you can see here, as the lung collapses and is reopened, you will then get release of inflammatory mediators both into the lung parenchyma itself, into the alveolar space, but also into the blood, into the circulation. And then those mediators will circulate to other parts of the body, for example, to the kidney, and cause acute kidney injury after the onset of initial lung injury. So this is referred to as biotrauma, which is distant organ injury from the release of inflammatory mediators into the circulation. So this is, again, how a patient could come into the emergency department, perhaps with a lobar pneumonia, but then within 24, 48 hours, develop acute kidney injury from these mediators that are being released into the lung. So that the way we manage the lung could have an impact in other organs. And it's something that we have to consider when we manage these patients. So here's a nice description that shows the various inflammatory processes that are occurring in the alveolus. You can see particularly what are called alveolar macrophages, which are macrophages that live in the lung, and they cruise around the alveoli looking for bacteria, but they also are potent sources of inflammatory mediators that you can see on the left here, interleukin-6, interleukin-1 beta, and many other proteases that then lead to this distant lung injury. So again, how we manage the lung has consequences downstream, if you will, with other organs. So going back to our CT scan, the challenge is that the lung is very heterogeneous. You see a pleural effusion here, you see some consolidated areas of the lung here, but then you also might see some areas of normal lung up here, and this is a gravity-dependent process. Obviously, as gravity increases going below the heart, you'll see more pulmonary edema here and less up here. So thinking about this and looking at this, you can then look at your ventilator waveforms and understand this further. So here's a pressure volume waveform of a ventilator, for example. Again, x-axis is airway pressure, y-axis is volume. And you can see that there's an area as the lung just begins to inflate, that where there's low compliance, and compliance is the slope of this line at any one time. You can see low compliance as the pressure increases. There's really not much lung recruitment, but then the lung opens up nicely. And then when the pressure is released, the lung then deflates. Now, these lines are different. In other words, the pressure at a different tidal volume is different on inflation versus deflation. And that, of course, is what's called hysteresis. Now, if you use excessive tidal volume, you'll see, particularly in an injured lung, you'll see a long phase where there's poor compliance. Again, the slope of this line is compliance, but eventually the lung will open. But then here you can see what we'll call a penguin beak because of the shape of this curve, looks like a penguin. And now you see a second area here, which is quite concerning, which is where, again, airway pressure is increasing, but we're not recruiting additional tidal volume. And this is thought where you can get volume trauma, literally ripping of the lung as you have excessive tidal volume for that particular lung, and again, deflation. So the idea of lung protective ventilation is to avoid these two areas. The first area I talked about where there was atolect trauma, where because the lung is collapsed and then you have to open it and close it repeatedly. And then avoiding this area here of excessive tidal volume. So we then reduce tidal volume and increase PEEP, which is here. And then we cycle through this sort of in-between phase where you have lower tidal volumes and higher PEEP, and you avoid both of these areas that appear to injure the lung. And indeed, this is a critical study here, which was, so, when I was in training many years ago, in the 90s, the concern was that really it was more high pressure that was a problem for the lung than it was high tidal volume. But in fact, this is an important study where Dreyfus, in a study using rabbits, basically in an iron lung type system that I showed you earlier. So they were actually able to generate high tidal volume, but with low pressure, because the rabbit's head would be outside of this box, if you will. They could then put very negative pressure in the box. The rabbit's head would be outside. They'd get very high tidal volume, but with low pressure. Or they could do more traditional ventilation with high pressure and high tidal volume just by doing a tracheostomy and turning up the tidal volume. And when they did that, they actually found that using low pressure, so in other words, the airway pressure is very low, but the tidal volume was high. In fact, the rabbit had more pulmonary edema and more protein permeability caused by tidal volume. And interestingly, if they had high pressure in the system, but with low tidal volume, there was very little lung water, pulmonary edema, or lung injury. And perhaps an analogy to that is when we take care of patients in the operating room, for example, for bariatric surgery, there's a very heavy chest wall. We have to lift that chest wall with a ventilator to be able to ventilate the patient. But those patients don't, in spite of high pressures, those patients don't develop lung injury. And the reason is because the chest wall is preventing the lung from being overdistended. So this was really important preclinical work to suggest that really tidal volume is a much bigger problem than pressure. And then if you can keep the chest wall from expanding, in this case in the rabbits, they actually wrap the chest wall in gauze to keep it from expanding, that it's really tidal volume that we should be focused on. And this led to what was arguably the most important study ever in critical care, which was what was called the initial ARDSNet trial, which just looked at the very simple question of how do patients do when they're ventilated with higher tidal volumes versus lower tidal volumes when they have acute respiratory distress syndrome. So this was a simple trial, and I'll add that there are factors here that it's more than just tidal volume was studied. I was fortunate to be a fellow and was able to participate in this study. Was skeptical that just tidal volume would make that big a difference. I will argue, though, that many of the things that this study did, which were equally important, was actually, this is really the very first protocol-driven care of patients in the ICU. So patients had to be on a very strict protocol, whether it was their mechanical ventilation or whether it was their weaning from mechanical ventilation. And as we know, protocol-driven weaning, particularly by the bedside providers, nurses, and respiratory therapists, improves care rather than clinician-driven weaning whenever the clinician might have time to make ventilator changes. But very straightforward, lower versus higher tidal volume, protocolized weaning, and it was 6 versus 12 mLs per kilo tidal volume. This is one of my favorite slides. It's sort of a Marie Kondo slide, if you will, and because it shows the importance of completing the study and not responding to temporary endpoints. So at day 0, both patients had pretty severe lung injury, the PA to FiO2 ratio of about 145. By day one, you'll see that, in fact, the higher tidal volume patients were doing better, at least if you define better as being oxygenating better. They had significantly better oxygenation by day 2 and day 3. So this is why we kept turning the tidal volume up in these patients with severe acute lung injury that had hypoxemia, because you would increase the tidal volume, there'd be some temporary resolution of atelectasis, and in fact, the PO2 would go up, which was the reason we increased the tidal volume in the first place. So this is an unintended consequence, because if you waited until day 4, there was no longer any difference between the higher and lower tidal volume. And you know that the answer is, when we looked at ventilator-free days, which were how many days in the first 28 days were you not on a ventilator, the patients with the higher tidal volume obviously came off the ventilator much faster than those with the lower tidal volume. In fact, they came off in half the time. So in fact, lower tidal volume was much better than high tidal volume. These are ventilator-free days. So how many days were you not on the ventilator? Much fewer days in the high tidal volume than with the low tidal volume. And most importantly was the difference in mortality at hospital discharge, and a quite significant difference, with 40% mortality in the high tidal volume, 30% in the low tidal volume. And of course, this has been adapted worldwide and has held up from multiple studies. So certainly in patients with injured lungs, this is the standard of care. Following that, there were some changes made in what were a subsequent consensus conference, the Berlin conference, which helped identify patients with acute respiratory distress syndrome. And really the only difference in this was that they could be stratified as having mild, moderate, or severe lung injury. And this is important as we then followed up this study with many other studies. But really the basic premise of the first ARDSNet trial has held up very well. And the use of low tidal volume, as I said, is a standard of care in acute lung injury. So following on to that study was, well, what else can we learn from this? Can we further refine our management of these patients? So one of the thoughts, as I showed you before, is that the presence of atelectasis was a risk factor for these patients. And so we do know that we can do recruitment maneuvers, certainly something, for example, in the operating room, higher tidal volumes had always been the standard of care. In fact, that had been the case in the intensive care unit. So we can do what's called a recruitment maneuver, which is really providing CPAP at about 15 to 20 centimeters of water for 30 to 40 seconds, perhaps, as long as the patient will tolerate it from the hemodynamic standpoint with the increase in intrathoracic pressure. And so this is something that we can think about. This is a nice study from Gattinoni in Milan, who did in animal studies. This is in a dog. And I think it shows very nicely the importance of recruitment maneuvers, or at least what they're effective. So here's a dog with what's called a oleic acid lung injury, which is an intravenous injury to the lung. You can see in this first image here, lots of atelectasis. Half the lung appears to be collapsed here. And as you increase the inflation pressure, you can see that the atelectasis begins to resolve, and you get, of course, very high pressures at 60 centimeters of water, the lung appears to be normal, at least fully inflated. And then as you deflate the lung, you can see something quite interesting. And again, it's this idea of hysteresis, which is, if you look at, for example, at a pressure of 30 centimeters of water, there's a lot of atelectasis on inflation, but on deflation, there's actually very little, if any. And so the idea is, once you've recruited the lung will remain open. And should we do this? And so you might determine what's called best PEEP, which is, what is the PEEP that's required to keep the lung open? Now, if you do this in humans, and this again is work from Gattinoni's group in Italy, they did a trial of 68 patients with acute lung injury and did CT scanning of all these patients to identify how these patients were doing in terms of lung recruitment. And what you can see is that they identified two populations of patients. The first population were those where there was relatively little lung that was recruited by this recruitment maneuver, so going from 5 centimeters of water to 45. And then another population of patients who had more potentially recruitable lung that you can see here. So in this case, here's 5 centimeters of water, and then you can see a lot of lung being recruited here, as opposed to what was happening in the patients who didn't have recruitable lung. But what was quite surprising to see was, when they looked at mortality as a function of how much lung could be recruited, they saw that the mortality was much higher in the patients that did have more recruitable lung that I showed you down here. And that was a little counterintuitive when I first read it, but it actually wasn't when you think about it, because what it meant was on the ventilator settings that were being used in this patient population, they were already recruited by the standard ventilator settings. And so the recruitment maneuver didn't really help them. These patients had more severe lung injury. And if you did an aggressive recruitment maneuver, you could show that the lung could be recruited. But in fact, what you were really finding was you just have identified that population of patients that had more severe lung injury. Another practice that has come into vogue or had come into vogue was the use of neuromuscular blockade early in acute respiratory distress syndrome using cisatracurium. The idea was that by paralyzing the patient, you could then optimize your mechanical ventilation strategy. You could use higher tidal volume. There wouldn't be any patient ventilator dysynchrony. And in the initial study that was called the AccuraSys trial in 2010, it showed a significant reduction in mortality in hospital length of stay and ICU and duration mechanical ventilation. But there was a lot of skepticism, and again, shows the importance of looking back at these trials again and understanding that as practice changes, that you have to look at it again. And when this trial was repeated, and this was called the ROSE trial, reevaluation of systemic early neuromuscular blockade, there in the repeat of this trial, they were unable to identify any difference between the two populations in terms of mortality, discharge to home. So in fact, this has really, this practice has kind of fallen out of use, particularly with better sedation techniques, and many studies showing the importance of early mobilization in these patients. Obviously, if you're paralyzed, you can't get out of your ICU bed. So this has really fallen out of practice, and it's rare that we have to use this technique except in the most desperate of circumstances. Well, we were all still, hopefully, or coming out of the COVID pandemic. But one of the things that was quite interesting, I think, early on was the observation that in patients with severe lung injury from COVID, that if you were able to turn them prone, particularly those that were not on mechanical ventilation, that they would get significantly better oxygenation. This was a very large-scale demonstration of the importance of prone mechanical ventilation. And of course, we knew this a little bit if you look at high-performance athletes. Here's somebody in the Tour de France, somebody climbing Mount Everest, that from an evolutionary standpoint, being prone provides better oxygenation than if you're supine or you're on your back. So in fact, this was, again, it's an article from the New York Times showed that this is something that we have to consider. And here you can see that when we're supine, the heart then compresses the lungs, and the majority of lungs are in the gravity-dependent part of the thorax. But if you turn prone and the heart rests on the sternum, then actually you have very little compression of the lungs, and the parts that might be compressed anatomically represent a smaller percentage of the gas exchanging regions of the lung. Of course, in the US, we like to have fancy gadgets. This is almost like a rotisserie where you can put, this was Vince Liu, one of our former fellows, now a faculty member, where you could put them in, and you could put the patient in, strap them in, and then turn them prone. But in fact, this is really not necessary. And in fact, Brochard in France and Gattinoni in Italy have shown that in fact you can do this quite easily in a patient just by turning them prone in the bed. And we've all become, I think, pretty facile with this. Of course, it's a time of potential risk because of dislodging the endotracheal tube or catheters or other things, but it's not particularly difficult to do. And if you do so, you can then recruit lung by turning the patient prone. And this was a nice study from that group called the PROSEVA trial, which was prone positioning in severe acute respiratory distress syndrome. Again, this was absolutely validated during the COVID pandemic, particularly with the initial wave of COVID, because the alveolar space was the part that was most severely affected by COVID as patients were coming into the emergency department with severe hypoxemia, as you just certainly found in Boston. In the protocol in the PROSEVA trial, 475 patients, and they spend most of the day prone, 17 hours prone. So this is one of the things that you have to consider, is that you have to spend most of your time prone. And then there were standardized criteria for when you could stop having to turn the patient prone. And importantly, all patients were treated with a protective lung ventilation strategy. And this was highly effective. Patients in the supine group had 28-day mortality of 33% and 16% in the prone group. So basically cut mortality in half with a relatively simple intervention. And this held up at day 90, still statistically significant. And again, ventilator-free days, the number of the patients spent fewer days requiring mechanical ventilation when prone ventilation was used. And here you can see the Kaplan-Meier survival curve showing a significant difference between the two. So this is clearly also standard of care, and again, was widely used during the pandemic. So if we think about what are the factors that are that we should think about when we're setting the ventilator, whether in the intensive care unit or the operating room, I think a more modern way of looking at this is what's called the driving pressure, which is the difference between the plateau pressure and PEEP. And so, of course, those are the two factors that can be manipulated. In this figure, you can see here's the peak pressure. Both of these patients have a peak, or in this setting, peak pressure of 15. But in this first case, the PEEP is 0. In the second case, the PEEP is higher at about 10. And so, in fact, the driving pressure, the difference between the two, is much higher in the first case than the second, in spite of them having the same peak pressure. Now, you can measure that. You can measure interpleural pressure or transpulmonary pressure using an esophageal balloon, as I've shown you here, just by putting this in the esophagus. And then the pleural pressure is transmitted to that balloon. And so if you look at driving pressure, I think much can be learned. And this is some nice work. Danny Talmore, shout out to Danny, at BI, participated in this. And this was just a reevaluation of 3,500 patients that were in the ARDSNet trial. So they looked at patients that all had a group of patients that all had the same PEEP settings, but had in five quintiles higher levels of airway pressure. The next group had increasing PEEP, but also increasing airway pressure. And the third group all had the same peak pressure, but increasing levels of PEEP. And what they found was in the first group, as the airway pressure increased at the same PEEP, mortality increased. In the second group, they found that as airway pressure and PEEP increased in parallel, the mortality stayed flat. But interestingly enough, in the group where the peak pressure was the same, but the PEEP increased, in other words, the driving pressure decreased, mortality decreased. So I think this was an important signal that if you look at driving pressure, the risk of death was higher as driving pressure increased. So this suggested that we should pay closer attention to how much PEEP that we're using. And again, here's Danny. I want to make sure that I call him out. So this was a nice study looking at an empirical study looking at higher levels of PEEP. So trying to look at driving pressure in a randomized trial, phase 2 trial. And so basically using esophageal balloon driven PEEP measurement, they were actually unable to show a difference. So a little disappointing in using, micro management of PEEP using an esophageal balloon. So what about in the operating room? Because we still worry about this there as well. There's been a couple studies that I'll show you quickly. One is by Foutier that looked at using low tidal volume in the operating room. So these are patients without lung injury, randomized between 10 to 12 mLs per kilo, traditional OR tidal volumes, at least historically, versus 6 to 8 mLs per kilo. And so what you can see here are the tidal volumes. So they achieved statistically significant volumes. The peak pressures were the same. But if you looked at the outcomes using this lung protective strategy, it appeared that it was better using the protective ventilation in these patients undergoing abdominal surgery. The length of stay was reduced as well, although not substantially. The outcome was looking at composite events. This is a composite of atelectasis, fever, respiratory failure, et cetera. There appeared to be a difference between these two groups in this population of patients. There was some skepticism, however, so this trial was repeated, what was called the iProve trial. And sort of long story short, when this trial was repeated, again, this was with a more widespread adaptation of protective lung ventilation. There was no difference between the groups. And a subsequent trial looking at much higher levels of PEEP PEEP use in the operating room, again, was unable to show a difference. So the last topic I want to talk to you about is something that we do every day, is we use oxygen. And the question is, are we using too much? Here's a study again from Mass General, Matthias Eicherman. I know he's moved on, but Marcos Vidal-Mello as well has moved on. But shout out to Mass General. And it was looking at randomizing patients to having a higher versus lower FiO2, 80% oxygen versus 30% oxygen. And what was found here is if you look here's the adjusted risk ratio. Here's the group with 30% oxygen. And those that had higher inspired oxygen concentration, again, had higher risk of a compositive respiratory failure, a lung injury outcome. So this suggests that higher inspired oxygen concentrations, at least in this setting, led to higher respiratory complications. Now, there's some controversy. The larger study that was published in the New England Journal called the HOT ICU study looked at targeting patients having a PO2 of 60, a little scary, a SAT of 90, or a PO2 of 90 with treatment up to 90 days. And this is both intubated and non-intubated patients. You can see here a nice separation between the two groups. However, there was no difference in outcome if you looked at the higher and lower oxygenation groups. So I'll conclude by saying that lung protection certainly is the standard of care in the ICU. We commonly encounter these patients with lung injury, or at least high risk of lung injury in the operating room, and we probably should be using lung protection in those patients. We really don't know what the right level of PEEP is, but certainly no PEEP is probably harmful, but some PEEP is good. And I wouldn't give up on PEEP titration yet. I think we just don't know how we should be doing it. And finally, I've certainly changed my practice to where I'm reducing inspired oxygen concentrations if it's unnecessary, as long as we can have acceptable oxygen saturations, for example, in the mid-90s. And with that, I will thank you.